So at this time, we will have our Q&A and then hopefully take a little bit of a break. Yes, virtual round of applause for Dr. Shalala. Thank you very much. We'll open it up for any questions for both Drs. Winsky and Dr. Kalelo on both of their talks before we take a break.
I have one question for Dr. Winetsky. So you mentioned the ADAP funding for newly diagnosed patients and how that's filling in the gap for patients who are traveling to the U.S. Is this an opportunity for advocacy? Is there any concern about that funding drying up or changing that we should have on our radar?
Not to my knowledge. It's a program that's been in place for like 30 years. So, it's a law that it's part of the Ryan White CARES Act of 1990. So I have but anything is possible in the current era.
I guess that was sort of where my thought was coming from, of like how some of these programs, which have been that were so mandated in the way that the Ryan White CARES Act was, and all the care that provided, as things have changed in our population in the United States, I wonder if that's something that is. So
we've just added to my many list of fears about what could be targeted by bad policy.
Fair enough.
But yeah, so far that seems to be a pretty good one. And it does, I will say that ADAP programs are a joint state federal endeavor. So the sort of health of the ADAP program varies widely from state to state. New York State has probably among the best ADAP programs. So.
Thank you, Jonathan.
Yes,
I should also just say on that, sorry, one thing. ADAP also there's a sister program to ADAP called ADAP PrEP. So ADAP in New York State actually also has an arm to provide coverage for PrEP for people who are at risk. So we also have undocumented immigrants receiving PrEP in our clinic. It doesn't pay for the medications itself, but our clinic has people who know how to get those medications provided for free from the drug company, and then it pays for the visits. Sorry.
You're good. Dr. Benson, to kind of go off of your question, I actually work for a Ryan White Part A program with the Department of Health at Mount Sinai, and we have been seeing an issue coming in with the renewal of ADAP benefits. We've been requesting a ceiling increase due to the amount of patients who either don't qualify for Medicare or Medicaid due to these instances and still need the ADAP coverage. New York State has a very strong legislation on making sure that ADAP gets renewed, which is why we had an actual tax increase last year to kind of replenish that, because the federal ceiling, when Trump was president, brought down the HIV ADAP protection on the federal level. So a lot of other states like Virginia, Georgia, and Washington itself currently have a 30% less income to fund their ADAP program. So they're working now on the federal level to kind of increase that and make it a federal protection on having across the board the same amount of funding depending on the population. So they're working on that now.
Thank you for sharing that.
Thank you.
You need to be worried.
Sage.
This is a question for Dr. Winetsky. You had recommended a large number of screening tests in asymptomatic immigrants, and typically in the emergency department, we're reluctant to send tests that aren't going to result during the patient's ED stay, and maybe aren't tests that we're that familiar with following up and understanding even how to interpret. So if we want to make sure that the patient that we're seeing in the emergency department gets all those appropriate screening tests, what's the best avenue for that? What would we send them to you? If we send them to our general primary care clinic, or is that going to ensure that they get the necessary screening tests?
I would imagine that there's no better way to make sure they get those tests than to send them yourself, because I don't think primary care clinics are you know, that this is necessarily on their radar. I've not seen too many other providers do this in general. And I mean, even within ID, I would say. You know, it's not something you can just send someone to STAR to do immigrant health screening. So, you know, I would just say, if you want to do this, just, I know it's not the easiest thing, but just send the serologies. And if they come back positive, you know, you can always reach out to us and ID, and we can help you sort it out. The ones I recommended are, you know, the ones that are recommended, it's sort of like, these are guidelines. The ones that are recommended by guidelines are pretty easy, you know, with the exception of Chagas. That one's more complicated to treat. But, you know, basically like 2 days of ivermectin is, you know, really straightforward for strongyloides. And for schisto, it's a little bit more complicated. So you would certainly refer them to us if it's positive, and, you know, we're happy to help. But yeah, I don't think that there's any mechanism for like sending people to a place to get those tests done that I know of.
Thank you. And I have a question for Dr. Colella. So these patients, did they get presented to the poison center via their primary care doctor? Were some of them emergency patients? And, you know, it looks like some of them were treated as outpatient versus inpatient. I'm just wondering, you know, what's the timing on getting them to chelation if needed, and/or continued follow-up?
Yeah, so the three patients that or the three scenarios I highlighted happened to come through somewhat unusual mechanisms in that, well, the refugee clinic. So a lot of our calls for blood levels do come from a primary care setting like that. Coming from labor and delivery is unusual because, you know, we don't often get blood levels on newborn infants. And then the gentleman with the supplements also came from a primary care office. However, many times the way the poison center gets involved is when a patient goes from the primary care center to the emergency department, seemingly often on a Friday afternoon. And then we get the call, you know, at the poison center, like, what do we do now? It is my practice and what we do, at least over here on this side of the river, that if you're going to institute chelation for the first time, particularly in a patient for whom you think the environment itself is the hazard, that I admit patients for that, even if it is with oral therapy. And the reason for that is that Suxamer is a little hard to give. Like I said, it's unpalatable, it's hard to get, it's in shortage. So writing a prescription for Suxamer chelation might delay that patient's care or their effective administration of the drug for a week or two. And then they're trying to take it in an already contaminated environment. So the default is to admit whether you're doing oral chelation or IV chelation, at least until you've better controlled the source and clearly established medication availability and administration.
Thank you. Thank you. That's very important to consider. Thank you. Do we have any other questions for our speakers? Great. So we have about 4 minutes or so before the next talk. And so please feel free to take a break, grab some coffee if you have coffee accessible. And I just want to thank you again to our first 2 speakers. You guys were excellent in starting us off for the day. So thank you very much.